Okay, thank you for the organizing team and especially Professor Matthijssen for the kind invitation. I think this talk will follow up on what has been discussed earlier. So I will briefly touch upon sleep disordered breathing in children with craniofacial malformations. And for this talk, I will mainly focus on craniosynostosis and children with cleft lip and palate, because this is where the evidence from the literature comes from. Then I will give you an introduction to drug-induced sleep endoscopy. We will see which data are available on this technique in children with craniofacial malformations, and we will discuss some outcome data. So, excuse me. So, as you probably already know, there is a large spectrum of sleep disordered breathing in children, ranging from simple snoring to severe obstructive sleep apnea, which is in children quantified as an obstructive apnea-hypopnea index of more than 10 events an hour. There are some particularities in children with craniofacial malformations because their sleep apnea presents differently than in otherwise healthy children that have their sleep apnea related to adenotonsillar hypertrophy. What we see in children with craniofacial malformations is that sleep apnea usually starts at a very young age or even shortly after birth, and is also associated with an obstructive breathing pattern, not only during sleep, but also during the daytime. And this is directly linked to the smaller airway caused by the craniofacial malformation. This can be associated with feeding difficulties and failure to thrive. And the failure to thrive might be related to the feeding difficulties, but also to the higher energy expenditure that these children have caused by their sleep apnea. We know that adenotonsillectomy can improve sleep disordered breathing in these children a little bit, but it rarely achieves a cure. It has an impaired quality of life. And we also know now that if you use questionnaires like the Bruyette questionnaire or the pediatric sleep questionnaire, that they score very badly. They have a very poor positive and negative predictive value. So you really need to have objective measures like polysomnography or polygraphy to document either whether there is sleep apnea and what's the severity of the disease. And of course, in the long term, the intermittent hypoxia and sleep fragmentation will also cause long-term morbidity in these children. This can be on neurocognitive outcomes, behavioral issues, and also on the cardiovascular outcomes. Then, when we look to the prevalence of obstructive sleep apnea in children with craniofacial malformations, there is a huge range. And as you see here, from 7 to 76%. And this is mainly related to the diagnostic criteria you use, whether you use some questionnaires or sleep studies, and also which population you have studied. And De Reclam and colleagues, they performed a study in 2010, and this was a population-based control study where they looked at cases with a code of obstructive sleep apnea from their inpatient database, and the controls came from a birth registry. And what they found is that a diagnosis of OSA was very strongly associated with the presence of a craniofacial anomaly. And you can see this in this table, so where the likelihood of having a diagnosis of OSA was much higher in children with cleft and also in the children with Down syndrome compared to the control population. When we look to which factors then contribute to the development of obstructive sleep apnea. So in children with craniosynostosis, studies have shown that those who have mid-phase hypoplasia are more likely to have more severe sleep apnea. We also know that sleep apnea as such can contribute to raising intracranial pressures. These children can have an additional condition of retrognathia, nasopharyngeal stenosis, as we will see in some of the videos. They can have adenotonsillar hypertrophy because they are children, and they also can have central neurological factors that come into play, which contribute to upper airway hypotonia. In children with cleft lip and palate, studies have shown that the craniofacial dimensions of these children, when you do long-term follow-up studies, that they are different from controls. They just have a smaller upper airway. And most studies have been performed in children with Pierre-Robin sequence, which have different factors that contribute to the presence of obstructive sleep apnea. We, of course, all know the presence of glossoptosis, where the tongue falls backwards, which is part of the diagnostic criteria. But these children have also an inherent increased upper airway collapsibility. They very often have a multi-level collapse of their upper airway, so not only a collapse at the level of the tongue base, but really also at the level of the soft palate. And there is a very high prevalence of laryngomalacia in children with Pierre-Robin sequence, which can also contribute to the prevalence of obstructive sleep apnea. Then when we look to specific subgroups, such as children with syndromic Pierre-Robin sequence, we also know that there are specific features. For example, children with Sticker syndrome, they have, in addition to the glossoptosis, midface hypoplasia. Children with 22q11 microdilation, they have retrognathia and a flattening of their midface, so also a retrusion which increases the narrowing of the upper airway. And children with Treacher-Collins syndrome, they have very well known multi-level upper airway obstruction and also some mandibular hypoplasia. And on top of that, we know that after pharyngeal surgery, there might be an increased risk of obstructive sleep apnea because you narrow the airway because of the surgery. And then finally, we have to consider that nasal obstruction is also very common in children with craniofacial malformations. And there might be different factors that are contributing to this. It might be associated with the original defect of the malformation, such as choanal atresia or piriform aperture stenosis. It might be a normal structure, like some adenoids, in an abnormal position or in a very narrow upper airway. It could be iatrogenic, for instance, after flap surgery, or stenosis, which is caused by inadvertent placement of a nasopharyngeal tube. And it could also be related to a residual defect. For instance, if you have a fistula after palatal surgery, this might then result in edema of the nasal passages and of the nasal mucosa, and by this contribute to nasal obstruction. But the importance of evaluating the upper airway in these children, it's not very new. This is a paper from Hans Hoeven from the Sophia Kinderziekenhuis, who already 25 years ago emphasized the need for endoscopic assessment in the upper airway. And as you can see, it's highlighted in this paper. They state that after polysomnography to document the presence of obstructive sleep apnea, the next step would be an endoscopy to evaluate the different sites of upper airway obstruction and to guide your management. So for that reason, I would like to talk more about drug-induced sleep endoscopy. And this is a dynamic, flexible endoscopy of the upper airway, which allows you to differentiate the different sites of upper airway obstruction, the degree of the collapse, and also the pattern of collapse. And this will then give you more information about the degree of compromise in this upper airway. And I'm very grateful to ERN CRANIO because I received the possibility to develop or contribute to a diced animation movie. And I'm happy to share this with you today. So when you look at it in this way, it seems very simple and straightforward. However, there are several challenges which are related to pediatric DISE. And it's because, first of all, it's an artificial and drug-induced sleep, so it's not natural sleep. In most cases, we need some inhalational anesthesia to get intravenous access, and then we switch to intravenous medication, either propofol or Dexdor in combination with ketamine. These are the two most commonly used drug regimens. It's performed in the operating theater, and it's really requires a close collaboration with the anesthesiologist to have this patient spontaneously breathing during the procedure while avoiding severe upper airway obstruction. And although DISE has gained a large amount of interest over the last years, there is a large variability in practice. And so for that reason, last year, we published 2 consensus papers with the International Pediatric Otorhinolaryngology Group on DISE in children. And this first paper, is more like a practical guideline where we discuss the different sites of the upper airway that have to be evaluated. We propose a scoring system, the Likert scale with 3 different grades, and you can see more technical details in this paper. And then parallel to this, we developed this scoring sheet so that on one page, you can really score the different sites of the upper airway. You can grade the severity of the upper airway obstruction, but you can also add some information about the movement, whether it's a dynamic or a fixed collapse, and what is the pattern, whether it's anteroposterior or circumferential. And of course, you can make some additional notes, like on which upper airway maneuvers you have performed during your procedure. And I will give you some examples of DISE recordings. So the added value, for example, in this video, you will see an epiglottis, which is completely collapsing and obstructing the upper airway. And probably the DISE is really the only way you can illustrate this, because with imaging studies, you will not be able to show this pattern of collapse. On the other part, you see huge lingual tonsils, which are blocking the upper airway. This is something that you could also visualize when you use, for example, cine MRI, but this is not very commonly performed in daily practice. When we look to the indications for pediatric DISE, as they have been acknowledged by different societies, then you see again that the presence of a craniofacial malformation is certainly an indication to have a proper upper airway evaluation. And this, I realized during the previous talk that we have these studies on the role of DISE in obstructive sleep apnea, but also to predict the chance of extubation in the patients. Also, this information can really be helpful and contribute to the airway management. So we will now briefly look to what's available in literature, and I will first focus on these studies that looked at drug-induced sleep endoscopy in children with Pierre-Robin sequence. So in this study, the authors looked at the degree of glossoptosis and the presence of associated airway anomalies. And they found that about 1/3 of the patients, especially the syndromic cases, had also concomitant upper airway anomalies that contributed to upper airway obstruction. Moreover, the authors found that there was a correlation between the symptoms the patients had in terms of sleep disordered breathing and the degree of glossoptosis, and also that, not surprisingly, the degree of glossoptosis, the degree that the tongue falls backward, was also associated with difficulties in laryngeal exposure. And so you can see this here. So this figure shows if you have grade 3, so really very severe upper airway collapse or severe glossoptosis, these patients have much more symptoms of sleep disordered breathing. As I already mentioned, that laryngomalacia is very common in children with Pierre-Robin sequence. And this is a very recent paper by Beekman and colleagues, where they studied more than 100 children with Pierre Robin sequence, and they found that about half of them had laryngomalacia. There was not really a difference in presenting symptoms, although these children were more likely to have also aspiration. And what the authors found is that in the children with severe Pierre Robin sequences, which were scheduled for mandibular distraction, they found that there was no improvement in OSD severity after supraglottoplasty, and that you only obtained an improvement if you combined supraglottoplasty with mandibular distraction. They could not draw any conclusions on the timing, whether you first do supraglottoplasty or whether you first do the distraction. However, I believe that in practice, because of this difficult exposure of the larynx, it will be often very difficult to have a good supraglottoplasty before you do the distraction. So often we would first do distraction, and once this has healed, then have a new evaluation and see whether there is still the need for doing a supraglottoplasty. And I will explain this with this case. So it's a case with a complicated Pierre Robin sequence with severe sleep apnea. The child has been on CPAP, and this was well tolerated for a while, but then he had a COVID episode, and this resulted in progressive worsening of his obstructive breathing, and also he started to become CPAP intolerant. We did a DICE, which resulted to an indication to perform mandibular distraction. And then after the closure of the hard palate, we repeated the DICE, and now we have a repeat polysomnography schedule. And so this is the first DICE that we do. So you see here, it's a bit bulky, soft palate. So the palate has already been closed. And then we see that there is a severe collapse of the tongue base, touching the posterior pharyngeal wall and also pushing the epiglottis against the posterior pharyngeal wall. But then when we look at the larynx and we relieve the charters, then we see that there is also severe laryngomalacia, which is completely blocking the upper airway. And then when we do the new endoscopy after the mandibular distraction, you can see that there is clear improvement of the obstruction at the level of the tongue base. There is still some palatal flutter, but also the laryngomalacia, it's no longer present. So the fact that we did the distraction also improved the collapse of the supraglottic structures in this case. So what we know on the role of DICE in children with craniosynostosis, this is also a study from the group of the Erasmus Hospital in Rotterdam, where they studied a group of children with Apert and Crouzon syndrome that were considered for mid-phase advancement. And it's interesting because at that time, the authors used the Bachar classification, which was at that moment the only classification that took into consideration a scoring of the degree of nasal obstruction. And we will see later on how important that this is. So most of these children had multi-level obstruction, and also again, the endoscopic findings correlated with the degree of OSA severity, and nasopharyngeal and tongue-based obstruction were considered the most common sites of obstruction. And so in this paper, they reported the details about the different procedures they performed related on the findings during drug-induced sleep endoscopy. And as you can see, most children really had an improvement of their OSA severity, reverting them to become mild or cases or even a complete cure of their sleep disordered breathing after DICE-directed surgery. I will now would like to show you one example of the severity of nasal obstruction, in this case with Crouzon syndrome. So it's a 4-year-old boy with severe obstructive sleep apnea. And you can see that we really had difficulties to pass with the endoscope through the nasal passages. There is a degree of nasal congestion and turbinate hypertrophy, but there is also certainly a degree of nasal septal deviation. So then we finally end up to the level of the nasopharynx. We see that he has also adenoids. And then in the other nasal passage, we see a septal deviation here. Here we end up in the middle meatus. And then finally, we pass through the nose. And then we see that in this child, there is a palatal flutter, but also a collapse at the level of the tonsils, which is contributing. So there is also this palatal flutter, the tonsils come to the midline, and also the tongue base, which is falling backward. So again, this nearly nicely illustrates this problem of multi-level collapse in these children. So I think in conclusion, the role of DICE in these children with craniofacial malformations, it can provide us more insight into the dynamics of the upper airway. It allows us to propose a targeted and individualized treatment plan to address these upper airway dynamics. It can also allow you to avoid unnecessary surgery and its morbidity. Studies that are available have shown that DICE-directed treatment may improve the outcome, but especially in children that have associated comorbidities, it's rare to obtain a cure after the DICE-directed surgery. So you have to be honest with the parents what you promise from your treatment. And this is probably also related because non-anatomical factors, so factors that we can't address with our surgery, also come into play. So in the future, I think it's important to further development the consensus protocol for DICE, and especially at the level of the drugs that we use. We should further explore the role of DICE in this endotype-phenotype approach, and so look at non-anatomical factors that contribute to sleep disordered breathing. And I think that DICE can play a role in the multidisciplinary management of children with craniofacial malformations, and that's why we are here all together. Thank you.